We are live.
A very good evening to one and all, and welcome to episode 80 of the postgraduate program by the All India Ophthalmological Society Academic and Research Committee. So, a very warm welcome to our examiners, mentors, as well as our presenters today. Today, we have a very interesting discussion on short case presentation. So, we have our esteemed examiners who are present here. A very warm welcome to you all. Dr. Varshini Shankar, who is the consultant pediatric ophthalmology, strabismus and neuro ophthalmology, Shroff Eye Center, Viva Vision, New Delhi. Welcome you, ma'am. Then we have Dr. Sulata V. Bandari. She is the professor and unit head, Department of Ophthalmology, KMC Manipal, Manipal Academy of Higher Education, Manipal. We welcome you, ma'am. And we have Dr. Vikas Kanojia, who is the professor and head, Sanjay Gandhi Postgraduate Institute of Medical Science, Lucknow. Welcome you, sir.
Thank you,
We have
madam.
our mentors. We have our mentors here. Dr. Parul Pujani, who is the professor, Government Medical College and Hospital, Chandigarh. We welcome you, ma'am. And we have Dr. Neena R, who is the senior consultant and head, pediatric ophthalmology, strabismus and neuro-ophthalmology, Girdhar Eye Institute, and Kochi. We welcome you, ma'am. And we have our presenters today, Dr. Surabhi Kapoor, who is a senior resident Government Medical College and Hospital, Chandigarh, who will be presenting a case on nerve palsies in TBM. And we have Dr. Sumina Jabbar, who is a primary DO DNB, Giridhar Eye Institute in Kochi. She would be presenting a case in papilledema. So all the best to both the presenters, and let's dive in the presentation. So we have our first case presentation by Dr. Surabhi Kapoor. So requesting Dr. Surabhi to please share your presentation. And we'll be having a discussion for around up to the first 30 minutes for the first presentation and the next 30 minutes for the second presentation. So all the best to you.
Are the slides visible?
No, ma'am.
No, not yet.
Just give me a second.
Yes, we can see the slides now. Yes.
Good evening, everyone. First of all, I would like to thank AIS for giving me this opportunity. So I would like to begin my case on nerve palsies in TBM. I will also be reflecting upon the ophthalmic manifestations of TBM. So before proceeding, I would like to mention that an informed consent was taken from the patient's parents, and all potentially identifiable information has been kept anonymous. So we're presenting a case of a 13-year-old female from Punjab who was evaluated in ophthalmology emergency of GMCH with the chief complaints of double vision for the past 3 days, which was gradual in onset, painless but progressive, lasting throughout the day. It was binocular and in horizontal direction. It was associated with headache, vomitings, and history of fever. Patient was admitted in the pediatric ward for the treatment of tubercular meningitis. Now, the global tuberculosis report of WHO suggests that children under 15 years of age do present with tubercular meningitis, and the global burden is around 12%, highlighting the fact how important is recognizing and managing pediatric TB. Moving on, the patient was apparently well 2 weeks back when she started having a fever, which was more in the evening, bifrontal type of headache, vomiting 1 to 2 episodes per day, however non-projectile in nature. The patient was taken to a local hospital in Sangrur for the treatment and was admitted for 2 days, records of which were not available. After the initial clinical presentation, after 2 days, the patient presented with seizures and altered sensorium and was referred to the pediatric emergency of our department. So the seizures occur in 34% of the patients with TBM, and it is seen that the incidence of seizures in the pediatric population is more as compared to that of the adult population because of the immaturity of the brain in kids. So the past personal and family history, there's no history of similar ocular complaints in the past. There is a history of open heart surgery for shunt repair at the age of 5 years at GMCH itself. There's no history of any diabetes, hypertension, or asthma. No history of tubercular contact in the family. The child was age appropriately vaccinated. She has also received BCG vaccine in childhood. Negative history, there was no abnormal head posture, no diurnal variation, no proptosis. There is no history of any trauma, any recent vaccination, recent ear infection, or history of any distorted images. So, on examining the patient at presentation, she was very irritable, semi-conscious, and not well oriented to time, place, and person at baseline examination. So, after 48 hours of admission, the patient was alert and conscious. Her vitals were stable. The systemic examination was largely normal, except that there was an upper motor neuron lesion sign suggesting of an upgoing plantar reflex response. That is, the Babinski reflex sign was positive, which suggests a cranial pathology. The systemic investigations were also by and large normal. However, when the CSF tap was sent, the cytology did show lymphocytosis, that is 60% lymphocytes were there. The albumin levels were also raised. The glucose was decreased. And this type of CSF cytology does corroborate with those patients suffering with TBM. We also sent a triple H serology, which came out to be negative for the patient. At presentation, we got the CE-MRI brain done. So we could see diffuse leptomeningeal enhancement in these patients. And there were certain ring enhancing lesions in the right parietal lobe of the patient, which was suggestive of tuberculoma. We could also see lacunar infarcts in the right middle cerebral peduncle, which was likely vasculitic on the T1 weighted images. Moving on, these are the various lesions, tubercular lesions, ring lesions that we could see, along with the perilesional edema that was seen in these patients. So we diagnosed it as a case of tubercular meningitis based on the clinical radiological suspicion, and then started the patient on ATT and supportive treatment. According to the Maria's criteria for diagnosis of TBM on admission, our patient had a total score of 13, which fits under the probable TBM. If a diagnostic score of more than 12 is seen along with radiological findings, it is probable TBM. This stresses upon the fact that how important is clinical and radiological, they have to come together in order to diagnose a patient with tubercular meningitis. On the fourth day of admission, the patient came to the ophthalmology emergency, and we did examine her for the we did do the ophthalmic examination. So the vision in both eyes was 6/6. Pupils were equal, round, reactive to light and accommodation. The Edenixa was within normal limit. Color vision, she could read all 38 on 38 plates. The anterior segment was within normal limits. The posterior segment, was grossly, we could not see any choroid tubercles on those patients. The cup disc ratio was also fine and normal background. However, on extraocular motility, we did notice an abduction deficit and also a dextro elevation deficit. So we asked the patient to undergo a diplopia charting. So as you can see in the diplopia chart, there is uncrossed diplopia, and the maximum horizontal separation is seen in the dextroversion gazes, suggesting that there is a right lateral rectus palsy. Since talking a word about uncrossed versus crossed diplopia, so uncrossed diplopia, as you can see in the picture, the eyeball is rotated inwards. So light, when it falls from the nasal side of the retina, will be perceived on the temporal side. So the second image will be formed on the temporal field in cases of uncrossed diplopia. In case of crossed diplopia, the image will be formed on the nasal side. On posterior segment examination, when we digged deeper into it, we could notice a subtle optic disc edema at the inferior pole of the eye. So we got OCT RNFL done. So on OCT RNFL, we could not notice any subclinical disc edema. However, the average RNFL thickness was slightly thinner than children of the same age. A study in IGO did tells that the average RNFL thickness is around 106 plus minus 9.3 microns in children, and it was less in our case. With this clinical background in mind, we had certain differential diagnosis. So the first differential diagnosis that came in our mind was sixth nerve palsy due to raised ICT in tubercular meningitis, owing to the fact of that there could be obstructive hydrocephalus. The points in our favor was lateral rectus palsy as the first sign of raised ICT. CE-MRI brain did show some perilesional edema with late onset seizures and subtle disc edema. We also thought about petrositis since there was a history of febrile illness, but there was no history of any chronic infection or facial pain. The patient had seizures and was on levetiracetam. So we thought diplopia is a known side effect of levetiracetam, but the diplopia improved after edema resolved and drug was continued. So we ruled it out. We also thought about pediatric IAH. However, normal CSF cytology and biochemistry seen in pediatric IAH, which was not in our case. So we reached at a conclusion that it is sixth nerve palsy due to raised ICT in tubercular meningitis. So we straight away started the patient on ATT DOTS regime as given by the RNTCP updated pediatric TB guidelines 2019. Our patient fits in the new clinically diagnosed rifampicin sensitive extrapulmonary TB. And we started the patient on 6 months of intensive phase and 8 months of continuous phase as is prescribed for neuro and spinal TB in these patients. So we also gave the patient injection dexamethasone to take into account the inflammation, levetiracetam for the seizures. And based on the clinical and radiological signs, along with the ophthalmic examination indicating the same, we gave the patient injection 3% hypertonic saline, given as an anti-raised ICT measure, and a lumbar puncture therapeutically was done, and 10 ml of CSF was drawn from L4, L5 in this patient. Summarizing, we have a 13-year-old female who, while undergoing treatment for tubercular meningitis, which included oral ATT DOTS pediatric regime, IV dexamethasone and levetiracetam, presented with the complaints of gradually progressing double vision, which was binocular, maximum in dextroversion gaze, associated with headache, fever, and vomiting. Examination showed deficient extraocular movements in dextroversion and elevation, and diplopia charting showed uncrossed diplopia with maximum horizontal separation of 18 inches. A repeat CMRI was done 4 days later. No obvious new infarct was seen. However, there was some perilesional edema, which was decreased as compared to that in the last CMRI. On day 8, the patient showed marked improvement in headache and diplopia. The right eye abduction deficit in dextrogases was significantly improved, and the diplopia charting also showed improvement in as compared to the previous visit. The maximum separation still being 18 inches in dextroversion gases. So moving on to the perimetry, although unreliable, but was grossly normal in this patient of ours. The patient was discharged 12 days after presentation. The optic disc edema at the inferior pole had reduced markedly, and the diplopia chart continued to show an improving trend. The maximum separation in dextroversion gaze reduced to 12 inches as compared to that of 18 inches in the previous visit. Moving on, after 3 weeks after ATT, when the patient came to us, her extraocular motility was full, free, and painless. The optic disc edema had resolved completely. And then we've also got the diplopia charting done, which showed marked improvement. And the patient was advised a 6 prism diopter based out to take into account the small angle deviation that was present in this patient. 11 months after starting the ATT, when the patient visited her, the diplopia chart showed no diplopia, and the optic disc also was also normal, didn't show any edema. Moving on. So the course of disease in our patient is 14 months of ATT were completed. Time to resolution of disc edema was 3 weeks. Time to resolution of diplopia was 10 months. And time to recovery of the 6th nerve palsy was 1 year in our patient. Just a case-related discussion, how important is ophthalmological manifestations in TBM. So what happens is, whenever there is a droplet infection, there occurs a primary pulmonary foci, which through hematogenous route enters into the meninges and brain parenchyma. These tubercular lesions remain dormant as rich foci in the meninges and the brain parenchyma. However, whenever there is some immunological compromise, these rupture into the subarachnoid space, may cause adhesions, vasculitis, or encephalitis. As in our patient, it causes adhesions in the basal cisterns, which lead to hydrocephalus. Interpeduncular fossa, when involved, may lead to cranial nerve palsies. Talking about an article that was published in the International Journal of Medicine in 2019 and the ophthalmic manifestations in patients of TBM, 9.9% of patients of tubercular meningitis had RNFL thinning. All of them had vision impairment. Reduced RNFL indicates axonal damage and thus shows how important OCT is as a tool as a non-invasive investigation to see the vision deterioration in such patients. So just a comparative OCT analysis, we could see there is no change or deterioration. However, the average RNFL thickness is decreased as compared to that of the Indian pediatric population. Talking about pediatric versus adult ocular manifestations of TBM, the pediatric cases have more of cranial nerve palsies and optic atrophy as compared to the adult, which have more of papilledema in these papilledema. And the various risk factors in pediatrics are the late presentation, hydrocephalus, and increased CSF count and protein level as compared to the adults. So moving on to the next slide, we were also scratching our head thinking why a BCG vaccinated child with such a good nutrition and hygiene developed TBM. So BCG vaccination does not totally prevent occurrence of TBM, but the children who have been vaccinated with BCG appear to maintain a better mentation and ultimately have a better outcome than the unvaccinated children. There's also various studies which tell us about the consensus that exists on benefits of prevention of severe form of childhood TB, including TBM and miliary TB. So in BCG vaccinated children in India who develop TBM, the clinical spectrum of disease does not seem to be ameliorated. Now talking about cranial nerve palsies in TBM, the problem is with misdiagnosis rate of TBM patients with cranial nerve palsy as compared to those without cranial nerve palsy. So the main misdiagnosis includes looking for an upper respiratory tract infection to say that whether the patient is having TB or not, meningitis due to other causes, cerebrovascular diseases. So if the patient cannot be diagnosed with TBM in time, more severe the cranial nerve palsy, the more likely concomitant with the disturbance of consciousness in these patients, and thus poorer the prognosis. Now, what are the causes of nerve palsies in TBM? So, the Mycobacterium tuberculosis, it causes exudative and proliferative lesions in the CNS. These exudates deposit in the subarachnoid space at the base of the brain and lateral cistern, which spreads around the brain and compresses the cranial nerves. Secondly, CSF circulation suffers interference, resulting in ventricular orifices and aqueduct stenosis and leading to obstructive hydrocephalus. Conversely, the excessive secretion of CSF brings about communicating hydrocephalus, causing the cranial nerves to be pulled and producing paralysis. Thirdly, it could be just occlusive vasculitis, which leads to cerebral stem infarction and stroke. Or there can be a direct placeholder effect of cranial nerve in subarachnoid space by tuberculoma or abscess. Now, what are the predictors of vision deterioration? Papilledema, cranial nerve palsies, raised CSF protein, and presence of OCA in MRI are the predictors. Our case had 3 of the above, but at the first sign of 6 nerve palsy, lumbar puncture was done and the pressure was relieved. Now, there is a contradictory view of the Indian and Chinese study as on which cranial nerve palsies are more common in TBM. So in TBM, in Indian studies say that 6th nerve is more common as compared to 3rd nerve, which is depicted by the Chinese studies. So in our patient also, we saw 6th nerve palsy. Now, what is the prognosis of 6th nerve palsy? So there is a highest incidence of mortality in TBM with 6th nerve palsy, followed by complete 3rd nerve palsy. TB was a mediating factor in acquired 6th nerve palsy in children. Now, due to this high degree of correlation with papilledema and raised ICT, lumbar puncture or surgical decompression is warranted on the first sign of 6th nerve palsy. So, moving on, it is also important to see whether the 6th nerve recovers or not. So in this study, published in Clinical Neurology Neurosurgery Journal, they showed that 70 patients, cranial nerve damage has almost recovered at 2 months follow-up post-ATT, and only 2 patients were left with oculomotor nerve and optic nerve palsy. So cranial nerve palsy, when treated at the right time, at the earliest, is reversible. Now, just a small look at other TBM cases in our department. So this is another case with TBM and nerve palsy. So you could see there's also a lateral rectus palsy in this patient. Moving on to the next patient. So this patient also had cranial nerve palsy. Along with, you can see some exudates on the MRI on the optic chiasma. So she was a diagnosed case of optic chiasmic arachnoiditis and was given treatment. However, we were not able to save the patient. This is a patient of TBM with disc edema. She's an 11-year-old female with bilateral disc edema, and we could see multiple tubercular lesions with the perilesional edema on the MRI images. Concluding, cranial nerve palsy is the most important neurological predictive factor to differentiate tubercular meningitis from other causes of meningitis. Timely lumbar puncture is very essential, helps in faster resolution of diplopia. Re-examine every 6 weeks after the onset of palsy until it resolves. MRI is indicated again if new signs or symptoms develop, abduction deficit increases, or palsy does not resolve in 3 to 6 months. Thank you.
That's a
Thank
wonderful
you.
presentation, Dr. Surabhi.
Thank you, ma'am.
Yeah. That was very detailed. There was a lot of your discussion was excellent. You've obviously gone into all the details of the presentation of the patient. So I think all our questions are essentially going to be what happens if you get this patient in your exam? Is your examination, is your presentation, is it sufficient for that? It's great when you have like a month to prepare and you're able to go into the literature. But when you get the patient in 10 minutes, then essentially what your examiner is going to be looking at is your ophthalmic examination of the patient and whether you're able to get all the science and of course the history. So
Yes,
I don't think there's anything to ask in the history. Your history was extremely detailed. But I'd like to go back to the slide where you first examine the patient, the diplopia evaluation
yes,
essentially.
ma'am.
Can we see that again?
Mm.
Yes,
Yeah,
ma'am.
rightly said by Dr. Varshini, because in your examination, because you won't be getting the patient into the emergency and they won't be asking you to go to the emergency and examine the patient. Definitely, the patient would be coming to you the after effects of TBM. You would be having a diagnosis, and the patient would be coming to you maybe 1 month, 2 months for your examination. I'm talking about, as Dr.
Yes,
Varshini has said. Now you can go back to the slide for the diplopia.
yes, ma'am.
Can you see?
No.
I was sharing the slide only. I don't know. Did it stop sharing? Let me just go through
Sure,
it
sure.
again.
She said that the patient was irritable. She was not able to do examination on the very first day when they saw the patient in the emergency.
So
Yes,
is this, yeah, wonderful. So, yeah, so over here, I would really say that at this patient, was the patient bedridden? Was the patient mobile? I
is
mean,
it,
you could
ma'am?
evaluate.
On the first examination, the patient was bedridden. We had
Okay,
to go to the pediatric emergency in
sure.
order to examine the patient.
Yes. But when you did the diplopia charting and all, I'm assuming this was a little later once they were.
4 days,
I,
ma'am. Yes. On
I
the
think it was
first
the
day of,
fourth day. Yeah, you
yes,
told
ma'am.
that it was the fourth day.
This was the
Okay.
4th day of admission of the patient.
Okay. So now, essentially, we are looking at this patient as a walk-in patient who's presenting with diplopia, which is
Yes,
what you will have in your exam, right?
yes, ma'am.
So what we want to look at is you want to keep the evaluation. Your evaluation needs to correspond with your diagnosis,
Yes,
essentially,
ma'am.
right? And we want to keep it as typical as possible so that your examiner is not diverted into asking you questions of atypical signs which are present, right?
Yes,
So
ma'am.
what I'm seeing over here when you're looking at this diplopia charting which you're presenting, the patient, would you be able to comment on what is not typical for a sixth nerve palsy?
Yes, ma'am. Ma'am, we could also see that there is some depression in the levo gases.
Yeah. So again, what I'm saying is that you're saying there is some amount of limitation of dextro elevation as well,
Yes,
right?
ma'am.
But in a sixth nerve palsy, especially in a small angle sixth nerve palsy, which is I'm assuming what you have over here, you
Yes,
would
ma'am.
expect that the incomitance is much more between the gazes, between the right gaze and the left gaze,
Left gaze.
Yeah,
right?
it is almost the same in the right and the left.
It's almost the same as well as
Same.
in the primary. There's not much
Yeah,
decrease between primary and the left,
yeah.
which is
Definitely.
not very typical of a sixth nerve palsy, or we would be looking at a bilateral sixth nerve palsy, in which case. right?
Yes, the child
Uh,
was giving very unreliable responses, and this was the most reliable information that we could get. This is very contradictory to the amount of diplopia that we are seeing on the charting. So the restriction is much less as compared to the diplopia which we were able to chart.
Absolutely. The other thing is, when you're presenting a patient with diplopia, you would be expected to do a prism alternate cover test to document the incompetence. The diplopia charting is actually much more cumbersome in your exam. It's much faster to do a prism bar cover test or a prism alternating cover test, and you'll be able to document the incompetence much better. We also want to know what the measurements are for near. All the
Okay.
gazes plus near is what is required to say that this is a sixth nerve palsy, that the deviation is maximum in the direction of maximum limitation.
Okay. Ma'am,
Yeah, so
actually, yes, ma'am.
no, that would be an essential. I'm just saying in an exam, that would be an essential part of the evaluation.
Because with this diplopia charting, you have to corroborate that the extraocular movement, as Dr. Varshini has said, that they were restricted in the left gaze also.
Okay.
Then definitely it shows that it is a bilateral sixth nerve palsy. The diplopia charting shows.
Right? The other thing which we would want is we would want a test of the sensory functions also. So you would want a Worthford dot test or a Bagolini's to show that there is diplopia as well. And you would want to comment on the stereopsis just as part of the format.
Okay, ma'am.
And you're also expecting that your angle is much less at near if it is a sixth nerve palsy. Right, so we wanted to fit into the pattern essentially. The one other lacunae in the evaluation was I don't think you commented on the other cranial nerves. Did you, or maybe I missed it?
No, ma'am, I didn't comment it, but we did
Yeah, she
examine.
has not commented. Yes.
So
Yes,
that is
ma'am.
essential. That is essential. If you're saying this is sixth nerve palsy, if you're
Yes,
saying
ma'am.
it's secondary to any form of intracranial pathology, especially a TB meningitis, which is a diffuse pathology, it's
Yes,
not a
ma'am.
localized pathology, you need to comment on seventh nerve, eighth nerve, especially because all the
Yes.
nerves travel together. So that would be a major lacuna in your evaluation, essentially. ठीक है. So all I'm saying is that in your examination, concentrate on the ophthalmic evaluation part of it because that is what you'll get the time for. You'll barely have 10 minutes. So history plus ophthalmic evaluation. The rest of it, everything was really good. Dr. Vikas, your comments?
Yeah, I think she has presented very well because it is elaborative, whatever the case presentation is. And ophthalmic part definitely needs to cover more. Eighth and seventh nerve definitely because basal meningitis is there in the TBM. So they
Yes.
are also affected. And because optic nerve definitely because at my center we are finding that TBM patients they come to us more over with the optic disc pallor many a times from the neurology department or with the decrease in vision, and that happens when the treatment has been started and the patient now from that your unconscious state patients gain consciousness. So definitely because seventh, eighth, and the other cranial nerve, that is the third, fourth, and that also needs to be mentioned. If you have examined for third and fourth people, I think you have mentioned. So
Yes.
good, elaborative, but it was covering more of the other part, covering your the test regarding the TBM because I think it was more so for that because it was tried to be with associated with TBM. Very good
Yes.
presentation, no doubt, because review of literature, comparing, definitely it was a very good presentation.
Yeah, Surabhi.
Yes, ma'am.
Yeah, yeah. As Dr. Varshini and Dr. Vikas mentioned, the presentation was very good. But as we all expected a postgraduate examination, it will be more of the history and ophthalmic examination and the diagnosis because so much of other details will not be available, nor you will have time to discuss that. And yeah, as a mention of like other cranial nerves, you should be including that. And here, since you went into almost like 1 year follow-up of the patient, what would you like to evaluate when follow? Like as Dr. Vikas said, after 2 months of starting treatment, everything when the patient comes to you at that time, what are the things you would like to evaluate in such a patient?
Ma'am, first of all, I would like to see whether there's any worsening of the gaze palsy or not. Whether there's the abduction deficit that was earlier that was there, whether it has improved or not. Later, I would also like to see whether there's disc edema or any other signs which tells us that there is progression of the initial presentation that is there, that is more of hydrocephalus, whether the ICT is raised or not. So starting from most important things are worsening of the gazes and the fundus examination. Plus, I would also like to do a perimetry, because when a patient is on ATT, then it is very important to see whether the functional visual outcomes is worsening or not. So perimetry can help us in it. The patient had a very good vision, so we can do that. So these are the three things, along with that OCT as well. So these are 3-4 things that I would like to see in every follow-up of this patient.
Good. Mainly the ATT or the toxicity effects you will have.
That's what.
Looking at it when you
Yes.
have a follow-up.
Yes.
So, Dr. Surbi, you would specifically mention ethambutol toxicity.
Yes.
Yes, ma'am.
When your examiner asks you what are you looking for on follow-up,
Yes,
you need
ma'am.
to come out with ethambutol
Yes,
toxicity,
ma'am.
right? That is one
And
thing.
color vision. These are simple things what you need to do. Yeah.
And one more thing I would like to add, because for the other cranial nerve, because you cannot do that, your tuning fork test and other tests, I think simple whispering test, that is, you can either get it from your ENT colleague. For eighth nerve, simple whispering test, I think you're on the bedside or when the patient is given to you for an examination, that will suffice for the eighth nerve.
Okay.
And in your history, when you use some terminologies like the basic things, you will not be using proptosis. Nobody will come and tell you I have proptosis. So maybe these things, minor things you can modify. Otherwise, good
Thank
presentation. Thank you.
you.
My
Yeah,
last
great
comment,
presentation.
sorry.
Yeah.
My last comment, Dr. Surbi,
Yes, ma'am.
since you mentioned follow-up on OCT, you would want, other than the RNFL, you would want to do the ganglion cell thickness as well,
Yes,
because
ma'am.
that is more sensitive to loss, especially early toxicity with ethambutol. Since you're presenting OCT,
Yes, ma'am.
I would, it's not only for disc edema, since you're monitoring toxicity as well.
Yes, ma'am.
So you would want to mention ganglion cell thickness as well, along with the RNFL.
And apart from your examination, Malab, this is for your examination purpose. If you are in your clinics and in OPDs as a resident, I think baseline VEP examination would also suffice for your this ethambutol toxicity and for monitoring of that your optic nerve function. Baseline VEP.
That was done, it was normal, and the macular
Achha, it
GC
was done. It was
also
normal.
checked it.
Okay.
Yeah. So since she just not put it, but it was done and normal.
Okay. Okay. Okay.
Okay. Okay. So very nice presentation. So I think we have a very nice discussion also. And so great discussions. Big round of applause for the presentation. Very nice. So let's move ahead with the second presentation. I'd like to request now Dr. Sumina to share her presentation. Yes, we can see.
Okay, good evening all. I'm Dr. Sumina Jabbar, second year DNB resident at Giridhar Eye Institute. I would like to
Sumina,
thank
please start
AIOS.
from the first slide. Your slides are not in the order.
Yeah.
I would like to thank AIOS for giving me this opportunity and also like to thank Dr. Neena ma'am, my mentor, for giving me support and support. So moving on to my presentation, I'm presenting a case of 22-year-old male patient who is from Ernakulam, who presented to our OPD with the complaints of intermittent blurring of vision in his both eyes for 2 weeks. History of presenting complaint. Patient complains of intermittent blurring of vision in both eyes, which he said as blacking out of vision, which lasts for 5 seconds and then it becomes clear. It is born during a morning time soon after waking up and is increasing in frequency day by day. He didn't complain of any headache, loss of consciousness, seizure, dizziness, dysarthria, vertigo, tinnitus, ocular pain, double vision, or any visual or auditory aura. There is no history of any fever, nausea, or vomiting. No aggravating or relieving factors like exercise or hot bath like that. There is no history of any trauma to the head and neck. Moving to his past ocular history, there is no history of similar illness in the past. He was prescribed spectacles 5 years back, but he was not consistent with that. There is no history of any surgeries, lasers, injections in the past. His medical history, he is a healthy, normal young male with no history of any diabetes, hypertension, ischemic heart disease, seizures, chronic cough, evening rise of temperature, joint pain, thyroid disease, blood dyscrasiasis in the past. Moving on to personal history, he is a student who is pursuing his graduation. His appetite is normal, bowel and bladder habits are regular. He's a non-smoker, non-alcoholic, and he is not under any addictions. His mother noticed snoring during sleep. Otherwise, sleep is normal. He is not on any medications, but he gives a history of recent weight gain of 10 kg noticed recently. Moving to family history, there is no history of any diabetes mellitus, ischemic heart disease, hypertension in the family, or a history of any similar illness in the family. He is not an allergic. Moving on to the general examination, he is well built and nourished. His BMI is 32.3, that is, he is obese. He is conscious and oriented. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. His pulse is 72 per minute, which is regular and normal in volume. His BP is 120 by 80 millimeter of mercury in sitting position. Respiratory rate is 18 per minute. There was no lymphadenopathy. He was febrile. There was no neurocutaneous markers on his skin. There was no pain over the temporal area of head. Moving to the systemic examination, the cardiovascular system was within normal limit. S1, S2 was heard. There was no murmurs and no bruit was heard over the carotid area. As respiratory system is within normal limit. Moving to the central nervous system examination, higher mental function is normal. Cranial nerve 2, 3, 4, and 6 are dealt with ocular examination. Otherwise, all other cranial nerves are within normal limit. His motor system is also within normal limit. Power, tone of the muscles are within normal limit. There was no sensory deficits noted. There was no cerebellar signs, and there is no signs of meningeal irritation was present. Moving to the ocular examination, head posture is normal. Eye is orthotropic. Both for dot, there is fusion for near and distance. No facial asymmetry was noted. Ocular movements were free and painless. Thus, vision is unaided vision is 6/9 in both eyes and improved to 6/6. Best corrected visual acuity is 6/6 with minus 0.5 sphere and minus 0.5 still at 180° in both eyes. Thus, color vision in both eyes were normal. Confrontation fields were also normal in both eyes. Moving to the anterior segment examination, this anterior segment examination is within normal limit and there was no RLPD. IOP was 13 by applanation tonometry and in right eye and 14 on left eye. Moving to the posterior segment examination, media was clear. His disc was hyperemic, elevated edematous with blurred disc margins and disc margins were blurred and the vessels were obscured within the disc and which was leaving the disc. There is obliteration of cup was noted and his vascular, moving to the, there was no spontaneous venous pulsations was not there. His vascular changes, there is dilated tortuous veins are seen and there is multiple yellowish hyperreflective lesions are seen, which is temporal to the disc and is seen radiating to the macula, just forming an incomplete macular star. And there is altered foveal reflex was there. His periphery was within normal limit in the right eye. And multiple hemorrhages are seen in the peripapillary area, more on the temporal, more on the superior quadrant. And in the left eye, all these findings were present in the left eye also. But apart from this, multiple concentric lines which are temporal to the optic disc are seen, which is indicative of pattern line. So this was his clinical fundus photography. So, moving to the summary, I presented a case of 22-year-old male patient who is otherwise normal, presented to our OPD with bilateral transient loss of vision in both eyes, who is otherwise systemically normal, apart from his weight gain of 10 kg recently and mildly obese. So systemic examinations, otherwise systemic examinations are within normal limit, and anterior segment examinations are also normal limit. Fundus examination revealed a bilateral papilledema of recent grade 5, most probably papilledema. Can you move on to the investigations?
Yes, you go ahead.
Or shall I stop?
No,
Okay,
you,
then, sir?
yeah, you go ahead. Your investigations.
Okay, so we did the RNFL and it shows edematous RNFL, and here we can see that the edema is extending near to the macular area with hard exudates are present, and in the right eye and in left eye also subretinal fluid is there. The ganglion cell layer shows nerve fiber defect, but his HFA was not reliable. There is, we should say some, there is enlargement of the blind spot. And we did an MRI which suggests an intraventricular central neurocytoma. That's all, sir.
Can you show the picture of MRI? Do you have that?
Sorry, sir, I couldn't get that
Okay.
picture.
Okay.
Let's go back to the examination.
Sure.
Yeah. The history, let's start. Yeah. So I just wanted to say you had a lot of negative history, but you need to know
Yes,
why
ma'am.
you are asking each of the points which you are asking, right?
Yes,
Yes,
Because there
yes,
were
ma'am.
a
very.
couple of things like history of snoring. So
Yes.
why is the history of snoring significant in this case?
If a patient presents with a bilateral transient loss of vision, it
Mm,
could be due to a raised intracranial tension and could be due to IH. And one of the secondary cause for IH is obstructive sleep apnea. And it can present as snoring occurs in obstructive sleep apnea, and it is a secondary cause for IH.
yeah, I understood. So all I'm saying is that all your negative history you need to be able to explain. There was one
Yes,
more
ma'am.
which I thought you had mentioned there was no pain over the temporal area.
Yes, ma'am.
Okay,
I
why?
would since he's a young man, it's not as relevant. But
Yeah.
in older patients, I want to rule out giant cell arthritis,
Yeah, but
temporal
then what you
temporal
need to
arthritis.
remember is that giant cell arthritis is not going to present with a passive disc edema with normal vision, right?
Okay.
So that kind of
Yes, yes.
becomes an irrelevant history in this case. So I'm just saying tailor your history a little bit towards what your diagnosis is.
Yeah,
Okay.
because your history part was very long and you were
Okay.
elaborating each and every point. Maybe you can say that
Okay.
there is no significant systemic history. Apart from that, these are the positive history point which I asked.
Okay, sir.
No, or at least tailor it to the age group. That's it. I mean,
Yes,
age group is
tailor to the
relevant.
age group also.
It is relevant if you
Okay.
ask history corresponding with IAH, of course, and corresponding with other
Okay.
causes for papilledema.
Can you go to the
Okay.
other slide also in the history? Just like why you have asked for diabetes mellitus over here, then again you are asking in the family there is no history of diabetes mellitus. Can you elaborate why diabetic mellitus you have asked?
Sir, systemic causes of hypertension, diabetes mellitus can cause ischemic ischemic changes and vascular changes, and this can cause production of emboli, which can cause ischemic strokes, which can be which can cause this
But
raised
with the
ICT
age
and
of with the age of 22, is there any relation with papilledema and diabetes mellitus? There is a relation. Do you know that? Because when you are elaborating diabetes mellitus, whatever you are saying that whatever aneurysm and this, they are not going to be related with that. But yes, diabetes mellitus history is related with this sort of fundus picture can be related. Okay. So
yes, diabetic, yes,
what you can think of with
diabetic papillopathy.
yes. So that much that as Dr. Varshini said that you should be able to explain why I asked this.
Okay.
Okay, appetite normal because appetite, as you said, that BMR, I think BMI was more than 30 something. Okay.
Yes. Yes.
So personal history student, matlab, you have to be tailor made because in your Viva examination you won't get much time. Okay.
Okay, sir.
Because if it would be a long case, so elaborate to that you should be able to explain. I asked this, and if somebody, the examiner, asks you why, if you have asked this, then you have to elaborate. Okay, I asked it, but I didn't mention over here because of the paucity of the time.
So, couple of similar points. You had also mentioned no bruit over the carotid and that confrontation fields were normal. Just be ready to explain how to check the bruit and how to do confrontation fields. You've also shown an enlarged blind spot on the field. So, you might
Yes.
want to show on confrontation how you will check the size of the blind spot.
Okay.
Okay, you may not have to
Okay.
do it, but you may have to at least theoretically explain how to do
Explain
it.
definitely, yes,
Can you
because you have
detect
shown
an
it, yes.
enlarged blind spot on confrontation? Because you've mentioned that it is normal, whereas your field
Okay.
shows quite a large enlarged blind spot.
Yes,
Right,
blind
so you
spot.
should be
Yes.
able to explain. I don't think anybody's going to ask you to do it, but
Okay.
you should be able to show
Because
it.
if it would
Okay.
have not if it would not have been a case of your intraventricular tumor, okay, because that explains that your it could be a obstructive hydrocephalus because of the intraventricular tumor. What could you have
Okay.
thought of other imaging apart from MRI? Suppose MRI came out to be normal, then you can fit it into a
Yes, sir.
case of IIH. Okay. So what finding can you
Okay.
get? You should know what other finding would you get on MRI, and what other investigation apart from your MRI you have to do to rule out the other secondary causes of IIH or the primary IIH.
So in MRI, there will be flattening of the posterior part of the block, empty cella will be there, and there is sinus stenosis of the transverse sinus stenosis can be seen, and the
No, on
perineural.
MRI you won't be able to see the stenosis of the transverse sinus. Okay, that is the
Okay.
reason I'm asking you. What is the
MRV.
investigation? MRV with
Okay.
contrast. Okay.
Okay. With contrast. Yes. And
Yeah,
other thing we
because
can do is lumbar puncture.
lumbar puncture is very important to rule out that tumor,
Yes.
because with that
Yes.
your diagnosis definitely then you would go for IIH, because that is
Yes.
intracranial hypertension and it
Yes.
would be more than 250,
More
220
than.
to 250. Yeah, then you would say yeah, because other things are normal, and then the ICT or
Yes.
ICP was raised. This is the reason my diagnosis, because male patients are not that much common. Young are common with the recent gain of weight, but more commonly in female. Male patient,
Modified Dante criteria, sir.
yeah, and MRV with contrast is very important.
Yes, sir.
Yeah, because many a time the transverse sinus seems to be collapsed. There
Stenosis.
is there is, because there are two school of thoughts. They say that the transverse sinus is collapsed because of your raised ICP, and the other school of thought said that transverse sinus was collapsed, and that is the reason for your raised ICP.
Yes. Yes, sir.
So, Sumina, will you go to the photograph of the discs which you had shown, the fundus photo? So, based on this photograph, can you grade the papilledema?
Yes, sir. Yes, ma'am. This is Fison grade 5 papilledema, as there is elevation of all around the disc margin, and there is obliteration of vessel within the disc completely, and other vessels are also obliterated, along with hemorrhages. Hard exudates are present in both eyes.
Okay, wonderful. When you see a fundus like this in a 22-year-old, before advising any other test, before OCT and all is not very relevant in this, because you know there's going to be severe edema. But
Yes.
what is the clinical test which you would like to do when you see this kind of bilateral disc edema in a
We should
young?
check the BP first
So how much was
to
it in
rule out
this patient?
malignant hypertension.
How much was it in this patient?
He is 120 80 millimeter of mercury. There was his BP was absolutely normal.
Wonderful.
Okay.
So once you've done your BP is normal, so you know that it is a true disc edema. You've gone ahead and done an MRI. You
Yes.
found that there is a space occupying lesion. What is your
Yes.
next step after which?
After which we have to refer him to a neurosurgeon or a neurologist for the management of this intraventricular mass, and we have to follow up this patient after the management of the intraventricular mass to rule out to know the visual outcome and to reduce the papilledema if needed. We can give treatment for papilledema if needed.
Have you followed this patient?
Yes, sir.
Have you followed this patient? Followed up this
No,
patient?
sir, he is yet to come. His surgery was
Okay.
over last week, and he is yet to
Okay.
come.
Okay. Because these are the most difficult cases, the intraventricular tumors.
Yes, sir.
Dr. Sumina, can you explain the pathophysiology of disc edema with increased
Yes, ma'am.
intracranial tension?
Yes, ma'am. Since the optic nerve is layered by the meningeal layers, and this CSF the optic nerve is bathed in the CSF, and so the intracranial pressure is transmitted to the optic nerve also, which causes an axonal stasis and retrograde axonal stasis, which presents as an nerve swelling and edema.
Wonderful. The other thing, as Dr. Vikas said, if we assume this is a case of IAH with a similar presentation, so what is your next approach? You've done an MRI, you've done an MRV, both are normal, maybe some signs of IH, as you said, posterior flattening of the globe, donut sign. What is your next step after which?
uh, while checking the MRI, we should rule out whether there is any chance of corning is there. And after ruling out, we should do a lumbar puncture, and we can assess we can confirm the diagnosis of IAH. And after that, we have to start our medication. Usually, carbonic anhydrase inhibitors like acetazolamide can be given if it is not vision threatening, and if it is manageable by that, we can start with a 250 milligram of acetazolamide TDS dose, or if it is a vision threatening condition, we should move to surgical procedures like ventricular shunt or optic nerve sheath fenestration like that.
Yeah, so in your patient, since the field involvement is minimal till now, and your vision is still
Yes.
6/6, so I'm assuming in this you would start with medical management,
Yes, ma'am.
right? How would you monitor the improvement once you've started
We
with
can
medication?
check for the vision, color vision. Apart from the ocular examination, we can do ganglion cell layer, retinal nerve fiber layer thickness, and we can assess the papilledema, whether it is going down or up, and we can monitor like that and do fields also, HFA also, whether it's affecting the vision, to check
So you
whether it
have
is.
to assess. Yeah, you have to assess both clinically, okay, and with the investigation. Color vision
Yes.
is of no use in these patients. If Dr. Vashini said, okay, presuming that this is an IIH, so color vision of not that use,
Will
okay.
be no. Okay.
Yeah, you have to
Yes, sir.
just clinically follow this patient with the fundus, your examination, and your clinical, the other investigative examination, as you said, macula, GCL, and your RNFL. But more importantly, your fundus examination, the symptomatology of the patient, as he was having that your blurring of vision for 5 TOVs over there, so they would get reduced, the headache would get reduced, okay. And you can increase the dose. It is not TDS. You can go up to 500 TDS, okay.
Okay. Okay, sir.
Yeah, it is
Oh,
250 QID you start with. And not,
okay.
yes, then you can add other furosemide and other your antidiuretics.
Sumina, can you just tell us the reason for the headache? Like, because we are all discussing headache, morning
Yeah,
headache.
yeah, I could explain. According to the Monroe-Kelly hypothesis, the intracranial pressure is a sum of CSF pressure, brain volume, and the intravascular compartment. And if one goes up, the other will go down. And if there is a raised ICT or a mass lesion which increases the brain volume, it will decrease the vascular component, which causes an ischemia, and it can result in a headache.
Reason for morning headache?
Because of the positional headache, because it causes the more accumulation of CSF within the brain, and it causes it's a positional or dependent headache.
Okay. The
Then
reason for having these hemorrhages and all, can you explain how does that? Like Madam had, Dr. Varshini had asked you about the pathogenesis.
Yes, ma'am.
We know about the
Due to
edema.
the
How?
leakage of due to the leakage from the blood vessels, proteinaceous materials get collected within, and it causes the hard exudate, and the ischemia to the blood vessels can cause these hemorrhages.
Okay. Then in your eye, if this patient who had IIH, other than estozolamide, what are the other treatment, like what are the things you would do in this patient?
We can
The
add
way
other
the history went
drugs
on,
like
we thought it's
topiramate.
100% IAH.
Okay. We can add other drugs like topiramate or furosemide. If it is not controlled, sometimes some people are doing sequential lumbar puncture, or otherwise it is not controlled. We can go for surgical management like ventriculoperitoneal shunt or lumboperitoneal shunt or optic nerve sheath fenestration.
Anything to do with this BMI, weight,
Yeah.
snoring?
Yeah, yes, yes, ma'am. Of course, we have to reduce the weight. Of course, weight reduction is the most important thing, I should say.
And the salt restriction diet, that is very important.
Last question from my side, Dr. Sumina. You mentioned optic nerve sheath fenestration. Can you tell me
Yes,
the
ma'am.
indication for that and also the steps? How is it performed?
Okay, indications are if the patient doesn't have other headache or other things, only if it is affecting the vision and the vision is severely affected, we can directly go for this optic nerve sheath fenestration. Actually, we are making some holes within the optic nerve sheath so that the fluid collected within inside is going out and the compression over the optic nerve is reduced. So, and we are reducing the edema over the axons.
What are the approaches for optic nerve sheath fenestration?
Uh, I think
You don't need to
it's
know the steps,
intracranial.
but you do need to know, what are the approaches, how to approach the optic nerve.
Okay, that I'm not sure, ma'am.
That's okay.
But you should know. Okay. There can be from the orbit, there can be from the sinus also.
Okay,
Endoscopic to the sinus.
Endoscopic.
Yeah,
okay.
some neurosurgeon do it.
Transsphenoidal, I think.
Uh, Not transsphenoidal because you have to go through the medial wall. So it is not
Okay,
transsphenoidal. Transsphenoidal, the approaches are for pituitary, okay, not for your
pituitary.
optic nerve.
Okay, okay, sir.
And one more thing, I think the spontaneous venous pulsation, you should know that it is present in almost 80% of the patient, 20% it is absent. So, because when you are
Which,
evaluating for papilledema, though this is a grade 4 or grade 5 papilledema, severe papilledema, but the early papilledema, you have to mention regarding the spontaneous venous pulsation also, whether you were able to see or not.
yes. If it is absent, it is a sign of raised intracranial pressure.
Yeah,
But
but with other sign also, not solely
okay,
that, because I told you that 80%
it
it
could,
is present, 10 to 20% it is absent. So with other signs, then you can add on, okay, the spontaneous venous pulsation I was not able to see. So this corroborates to what this becomes helpful in early papilledema, because many times there is a doubt whether the papilledema is there or not. And then there is your ultrasound, okay? The
okay,
transverse
these,
ultrasound, yes, your crescent and your that the subarachnoid space, you see that hollow, the hypoechoic area. So that also corroborates in early papilledema, not in established papilledema. Right? That because that established papilledema is all obvious on your fundus photograph. Fine. Early papilledema, there are other confirmatory, or you can say the test are. So one is your ultrasound also. So overall, it was a nice presentation.
thank you, sir.
So
No, it
both
was
of the
a
cases were
very
very
good
nice.
presentation, and you've
Yeah.
obviously read up on the case very well.
And
Nicely
this is how you have to
presented.
go about. This is how you have to go about in your examination. Then we would consider that the task that was given to us and that the AIS is now just on. The PG should present like this. And if every PG is presenting like this, I think the task of the AIS has been done.
So, can I stop sharing?
Yes.
Yes, you can.
I just wanted to add that this patient, we also thought initially it was IH. So just wanted to present this case for the PG so that every case which you think is typical is need not be what you think. So the imaging is extremely important. So they should not shy away from imaging They should not send the patient to the neurologist. We can actually diagnose. As ophthalmologists, we diagnose, we refer the patient to the neurologist, then we follow them up. So there is a very strong connection between the neurologist and the ophthalmologist in following up these patients. So I just wanted to present this to show that.
Yeah, definitely. It
Very
was a
well
nice
said.
message. Yeah, it was a nice message because we can go for the MRI and we should know how to order and what to order. That is also very
Yeah.
important.
Yeah, and the investigation of choice in a papilledema is a contrast enhanced MRI with MR venogram so that we don't miss
Yeah,
the dangerous conditions and then we can rule out. Then drugs also should, as she said, secondary IH should also be ruled out. Like we had the other day a patient who was on vitamin E tablets and sticking, so that was something which can cause secondary IH. Anemia is also something which is thought to cause secondary IH, tetracycline. So some drug history also can be elicited, which could be responsible for secondary IOH. So just wanted to impress upon the postgraduates the importance of imaging in a patient with papilledema.
yeah, and some other blood investigations like your APLA, the protein C, protein
Yes,
S. Yes,
atypical.
they have
Yes,
also be. Yeah,
atypical cases definitely. In the first line, or nothing is possible is coming out right, then definitely second line.
yes.
Yeah, definitely hematological, complete hematological investigation,
Evaluation is
vasculitic
very
workup,
important. Yes,
APLA, anticardiolipin antibody, all those things also need to be done.
yeah.
So we have picked up protein C, protein S deficiencies also
Deficiency.
rarely
Yes,
as
yeah.
causes of, raised ICT. Rare cases we
Yes.
have picked up.
As a resident, you should know all that procoagulant stages also and the factors affecting your that coagulation and causing that your towards procoagulation. Because young patient, so these investigations hematological also very important. I think we are done with very good
Yes,
presentations, both of
we
them.
are overshot, I think, time by
Yeah,
one
almost
Exactly
minute.
done.
by 1 minute. So I think we'll
Dr.
end the
Anakha
session
is
over here.
there to say the
Thank you.
parting remarks.
Yes.
Yeah. So I just wanted to ask Dr. Parul, I have a genuine doubt regarding this TB. We don't see, as a standalone eye hospital, we don't see such sick patients with TB meningitis. But you have the multi-specialty setup, so you'll be seeing such sick patients. So when you're starting, you started the patient on ATT and you started the patient on dexamethasone, no? So how long will you be giving the dexamethasone injections? Do you then put them on oral steroids or just a short course of IV dexa?
This is managed from the pediatric sense. So as far as from the pediatric side, so as far as I know, it's just a short course of DEXA. Initially, when the bugs start dying, the TB bugs, the mycobacterium starts dying, it's going to exacerbate the inflammation. So DEXA, I think they give in slow tapering doses for a few days. For this child, they gave since they saw that the perilesional edema was reducing, so I think they just gave IV for in the slow doses for a week, 10 days, and then they stopped it. But I think different centers have different protocols when it comes to steroids. Uh, Preferably, if the tuberculomas are much more and if there is more perilesional edema, oral tapering doses with slow tapering should be given because as the mycobacteria are going to die, all that could lead to paradoxical worsening also of the symptoms. So that's something that needs to be titrated, but it's primarily a decision which is taken by the pediatrician. So if only we see worsening, we would like to contribute from our side, but essentially, yes, it should be given, as long as you see that the patient
Yeah,
is
because it becomes life-saving. Only
absolutely.
ATT won't work, yes, because the perilesional edema or the brain edema, definitely it becomes life-saving.
Yeah, also the paradoxical worsening would be taken care of if you
Yeah,
give
would be taken care of.
steroids. Yes,
Yes.
yes, yes. I think it's time to conclude that.
Time, I
Yeah,
think
it's
Dr.
time to
Anakha has
conclude.
an emergency, so I think she's attending an emergency probably.
Okay,
We
so it
just
was very
you can.
nice interacting and very nice presentations. And PG definitely must have had learned how to present and how to examine and the inputs given by all the experts. I think the PG definitely have been benefited.
Thank
Thank
you, everyone. Good
Thank
night.
you,
You.
everyone.
Good
Thank
night.
Good
you.
night.
Thank
Good night.
Thanks,
you.
ERC, for the
Good night.
opportunity. Good luck to all both the PGs. and good job by mentors. Thank you.
Okay, thank you, ma'am. Thank you.
Thank you and good
Okay.
night.